everyone, and thank you for joining us for tonight's program. I'm Kathleen Davis. I'm the Executive Director of the National Kidney Foundation of Eastern Missouri, Metro East, and Arkansas. Welcome to our professional education program, Nephrology Care Challenges and Clinical Innovations for the Community, a roundtable with St. Louis Nephrology Fellows presented by the Fellows of St. Louis University School of Medicine and Washington University School of Medicine. Tonight's Renal Roundtable is in association with Dr. Lentine and Dr. Miyata of St. Louis University School of Medicine and Dr. Alhamad and Dr. Goldberg of Washington University School of Medicine. Thank you so much for your collaboration throughout the planning and implementation of this important program for the renal community. We have a great program in store for you this evening and appreciate your time spent with us, as your expertise is valuable to the success of tonight's engaging discussion. I'd like to share an upcoming event reminder for our local NKF market. I encourage you to participate in our upcoming St. Louis Kidney Walk on Sunday, March 23rd at 11 a.m. Hope to see you all there. Registration is open on our website. Also, next Thursday, on December 12th, Outsica will be hosting a renal roundtable at Bristol Restaurant at 11801 Olive Boulevard. Dr. Lorma will be presenting on IgA nephropathy, and please join us for that. After each institution's fellows presentation, we will have a Q&A portion. Please feel free to raise your hand and ask questions at this time. Now I'd like to thank our sponsors, for without them, this would not be possible. Thank you to our presenting sponsor, Therapeutics, our gold sponsors, Alexion and AstraZeneca, and our silver sponsors, Chiesi, Otsuka, Amgen, Calliditas, Akebia, Artilex, Aurinia, Baxter, CareDx, Fresenius Medical Care Nephrology Connect, CorMedix, Boehringer Ingelheim, Merck, Eisai, Natera, Novartis, Novo Nordisk, Next Stage, Fresenius Medical Care Renal Pharmaceuticals, Bayer, and Mallinckrodt. Thanks for allowing us to gather and supporting this evening's program. Now it is my pleasure to introduce Meghan Schultz, MPH, Population Health Partnership Director at the National NKF. Meghan has played an instrumental role in furthering NKF's mission, previously lending her expertise to the planning and execution of our local Fellows Renal Roundtable. On the National Population Health Team, Meghan is dedicated to driving a cultural shift in Missouri, Illinois, and Minnesota by spearheading upstream strategies to improve early diagnosis and appropriate proper management of CKD across the primary care setting. Tonight, Meghan will be our event facilitator, keeping us on track and navigating our packed agenda. She'll be introducing our esteemed presenters and guiding us through the presenters' topic for the evening. Without further ado, let's extend a warm welcome to Meghan Schultz, and thank you for steering us through this important event.
All right, good evening, everyone. Thank you so much for joining us. We're really excited about tonight's packed agenda full of dynamic presenters and wonderful content. I'm really excited to get us started here and would like to first begin to welcome Dr. Krista Lentine, who pioneered the idea of the Fellows Renal Roundtable and has really remained steadfast in her ongoing support and dedication to NKF's mission. So Dr. Lentine, please.
Thank you. All right, well, good evening, everyone. And on behalf of the SLU Nephrons team, we are so delighted to be part of this 4th annual Renal Roundtable event in partnership with the National Kidney Foundation. And we'd like to express our most sincere thanks to Kathleen, Courtney, Juliet, Meghan, Maggie, and the entire NKF team for support of this wonderful event. And we also thank our colleagues at Washington University for the invaluable collaboration. And as mentioned, the Fellows Renal Roundtable is a program we started in 2020 when I first approached Kathleen with the idea to hold a local conference showcasing the work and education of the outstanding fellows in our region. And we're so glad that Kathleen and her team embraced the idea and have done substantial work, as you're seeing tonight, to make this event a reality. We've learned a lot along the way, and we hope the event both celebrates what is going on in the renal community as well as inspires more trainees to enter what is definitely the best medical specialty, nephrology. All right, back to that. So representing SLU, we have two excellent fellows presenting tonight. They are here as representatives of our training program, including co-fellows, many of whom are here supporting, as well as our full faculty and staff, including our fellowship coordinator, Jessica. The mentorship group on the SLU side for this roundtable includes multiple faculty who have helped in different capacities over the years, including Dr. Miyata, our new fellowship program director, who will be speaking shortly, as well as Dr. Philip Neri, who's been a mentor throughout. And among the thanks, we again are very grateful, as Kathleen mentioned, to the event sponsors for their support, and to all of you attendees for your engagement and robust participation. So now I'm delighted to pass the podium to my colleague and friend, Dr. Alhamad, who will share a few words from the WashU perspective.
Thanks, Dr. Lentine, for the introduction. I don't have the other many photos. I just have my photo here. So this becomes as a tradition. Every year we have fellows from WashU, fellows from St. Louis University, and some years we have fellows from the University of Missouri in Columbia, where we get together, enjoy their presentations, go through the new advances of nephrology. The nephrology field has been quite exciting, but in the last year or two there have been more new excitements with a lot of new therapies, tons of clinical trials, complements, IgA, antibody-mediated rejection. This is really a very exciting time of nephrology to be in. So we are enjoying and celebrating these presentations with the fellows today. I want to thank Kathleen, Meghan, and all the NKF team. I want to thank all the sponsors. It's really wonderful to meet all our colleagues from SLU and the community nephrologists to celebrate this event. Thank you all for joining us. Without further ado, we'll proceed with the event. Meghan?
Wonderful. Thank you so much, Dr. Alhamad. Now we have the privilege of hearing from Dr. Miyata of SSM Health St. Louis University Hospital, who is eager to introduce their fellows and their upcoming presentation to follow, Salt and Body Works, a contemporary approach to sodium intake in CKD patients.
Hi, good evening, everyone. My name is Kana Miyata. I'm the new program director from this year. We have 7 fellows at SLU, 4 fellows in the second year, and 3 fellows in the second year and 4 fellows in the first year. Today, I'm gonna introduce one of the excellent chief nephrology fellow, Dr. Shannon Ejiofor. Shannon has been an integral part of our program as a chief fellow, not only from excelling in her clinical responsibilities, but also demonstrating remarkable leadership qualities. As a chief fellow, she has been the backbone of our scheduling system, always ensuring things run smooth and on time. Shannon's journey in medicine began at William Carey University College of Osteopathic Medicine in Hattiesburg, Mississippi. Then she proceeded to internal medicine residency at the University of Missouri in Columbia. Outside of medicine, Shannon enjoys reading and exploring diverse culinary experiences. Recently, she particularly likes Korean, Vietnamese, and Thai foods. I'm sure you will enjoy her presentation today. Thank you, Shannon.
All right, thank you so so much, Dr. Miyata, for that great introduction of Shannon. And I'm also delighted to introduce our second fellow, Dr. Rengin Afsar. Dr. Afsar completed medical school, internal medicine residency, and nephrology training in Turkey. Rengin actually came to us as a very experienced clinician, as she was also a practicing nephrology attending in Turkey, and we're fortunate that she decided to bring her family on an adventure to the United States to pursue U.S. training. And as a bonus, she brought her husband, Dr. Baris Afsar, who is also a valued member of our fellowship program. In their initial time in the U.S., Dr. Afsar served as a research scholar at Vanderbilt, where she worked on studies related to one of her passions, metabolic health in kidney disease. Of note, Rengin is a talented writer. She has authored more than 100 articles, including an excellent paper coming out for our transplant team on genetic evaluation of kidney transplant candidates, out any day now, so I encourage you to look for that. And as you will hear in a moment, Dr. Afsar is a talented speaker who has given more than 60 national and international conference presentations. And last but not least, one of the most notable characteristics of Dr. Afsar is her true sense of joy. She loves every aspect of her work, from research to writing to patient care, and even when the services are very busy, she always comes to the clinic and rounds with a smile, which really always brightens my day. She is a devoted wife and mother, and quickly became known in the SLU Nephrons family for her kindness and enthusiasm that inspires us all to do our best work. So welcome to the podium, Dr. Afsar.
Good evening, dear colleagues, and it's my privilege to speak here about our topic, the salt and body works. We have the following objectives of our presentation. First, we will describe the effects of sodium in the body, and we will present a case of hypertension to highlight the management of blood pressure, high blood pressure, and we will discuss the relationship between sodium intake and proteinuria and CKD progression, and the relationship between sodium intake and cardiovascular events. We will list the methods for estimating dietary sodium intake in CKD, and we will list the strategies for salt restriction in CKD. As you all know, sodium is very well known for its vasopressor effect, but besides being a vasopressor, it's an immunomodulator, a micronutrient as well. In fact, it's more than an essential micronutrient. High salt intake increases the sodium concentration and increases the osmolarity. And high salt intake has hemodynamic effects, and it increases sympathetic nervous system activity, cardiac output, and peripheral vascular resistance. And besides hemodynamic effects, it negatively impacts the vasodilation mechanisms, like it causes endothelial dysfunction, it increases sympathetic nervous system activity, and it impairs the pressure natriuresis, and in turn it causes hypertension. Amongst the, besides the hemodynamic effects of sodium, sodium also is an immunomodulator. The very well-known effect of sodium is that it causes the differentiation of CD-positive T cells to T helper cells, and which favor the macrophage differentiation. And the T helper cells to T regulator cells ratio is increased in high salt intake states, which is a risk factor for inflammation and autoimmunity. Both high sodium and low sodium are pro-inflammatory. It's very interesting to know that. We all know about the negative impacts of high sodium, but low sodium is also a stimulus for pro-inflammatory cytokine secretion. In addition, high salt causes abnormal leukocyte and endothelial cell interaction, and it causes vascular endothelial dysfunction. And the global sodium intake varies between 3.5 to 5.5 grams per day, which corresponds to a salt intake of 9 to 12 grams per day.
So, let's meet my patient, Mr. Salty. This is a 72-year-old male. He has a history of chronic kidney disease, G3A2, hypertension, OSA, obesity, and nephrolithiasis, who presents to your clinic for a follow-up of his chronic conditions. Okay, so he reports to me mainly eats a meat and potatoes diet, very few vegetables, a lot of diet colas to offset all the meat and potatoes, no dairy, and heavily salted foods as well. He reports no stones within the past year, and also he has minimal cardiovascular activity with a BMI of 35. Blood pressure medications, he's on several, including hydrochloric iodide, lisinopril, carvedilol, and recently added amlodipine. Per his wife, he adds just enough salt to where you can see the white on the food. So, being the very astute nephrologist that you are, and being thorough and looking back at his labs, you look at his urinary chem panel and notice an association with the sodium excretion and his blood pressures. So 6 months ago, you saw his blood pressure is 136 over 90, sodium is 216. 3 months later, a little bit of higher side, 147 over 89, more salt in his urine, and at that time he added amlodipine, like I said in the beginning. And this time, blood pressure is 162 over 97, sodium excretion of 500. So, Mr. Salty had a problem. He had uncontrolled hypertension. So, additional workup that you did, and you got an ambulatory monitoring blood pressure, showed his mean blood pressure was 151 over 96, and he did not dip at night. Additionally, his secondary hypertension workup was unremarkable. So, you advise him the following interventions to decrease his sodium intake per the KDIGO guidelines to less than 2 grams per day, or like Dr. Afsar said, 5 grams of table salt per day. Increase his aerobic physical activity to decrease his body weight, and increase fruits and vegetables intake. But Doc, how much exactly is 2 grams of sodium or 5 grams of table salt? Exactly. So, this is going to be a little bit interactive, okay? First question, which one of the following is equivalent to 5 grams of salt? Is it half a teaspoon, 3/4 of a teaspoon, 2 teaspoons, or 1 tablespoon? I am going to ask you all just to raise your hands. So, who says half a teaspoon? Anybody? Okay. 3/4 of a teaspoon? Raising hands. Okay, I see some hands. 2 teaspoons? Okay, I see more for the 2 teaspoons. 1 tablespoon. Anyone says tablespoon? Okay. Well, actually, it's 3/4 of a teaspoon is equivalent to 2 grams of sodium, aka 5 grams of salt per day for all meals, okay? Which is kind of hard considering that some of our sauces are highly salted with sodium. So like if you cook with soy sauce, it has 960 milligrams of sodium per tablespoon. Fish sauce has 1.4 grams of sodium per 1 tablespoon. If you like oyster sauce, 0.8 milligrams sodium per tablespoon, or you can just want a good old sandwich, turkey meat, turkey deli meat, because you're healthy, but 2 slices has 0.5 grams of sodium, okay? But of course you're gonna have some ketchup with it, right? So that's 170 milligrams of sodium per tablespoon because you measured it out, right? All right, and then of course you have to have a side of chips. That small bag, again, 170 milligrams of sodium. And that's if you only have 1 bag, right? So, question 2. Does restriction of salt intake decrease proteinuria or progression of CKD for Mr. Salty? Yes or no? And I think Dr. Afsar will be able to answer this question.
Yes, I will present the data about restriction of salt intake and CKD progression. There are multiple studies, not specifically working on this issue, but more of a collection of data were analyzed and some results were brought up. First of all, this is the CRIC study, the chronic renal insufficiency study, and in this study, the patients with the lower in the lower quartile of sodium intake, like 116 millimoles of sodium per day, were compared to the highest quartile of 190 millimoles of sodium per day, and compared with the lowest quartile, the patients in the highest quartile had 1.5 times higher risk of CKD progression, and this was the result of the adjusted analysis. And the data was further adjusted for the systolic blood pressure, and the interactions remained significant. And the patients with the highest quartile of sodium excretion had 1.4% of increased risk, 1.4 times increased risk of CKD progression. And this is another study, the NO-CKD study analysis. NO-CKD study is a Korean study, a nationwide multi-center study. And in this study, the baseline sodium restriction was determined as the sodium intake between 104 to 145 millocalories per day. And when, according to the reference level, as the sodium intake of the patients increased from 145 and over, the risk of CKD progression increased linearly. For instance, in the patients consuming sodium between 145 to 190 millocalories per day, the risk was 1.6 times higher in these patients than the reference group. And as the sodium intake increased, there was a linear relationship for the risk of CKD progression. At a consumption of sodium 120 millocalories per day, each 100 millocalories of sodium intake increase in sodium intake increased the risk of CKD progression by 1.5 times. This shows the relationship between the linear relationship between the sodium intake and risk of CKD progression. And this is another study, and this is the analysis of the combined on-target and transient trials. And these trials included patients over 55 years of age who had established cardiovascular disease or diabetes with target organ damage. That means that these patients were at high cardiovascular risk. And the primary outcome was a decrease in Ejiofor more than 30%. And in the overall analysis, there was no difference between the primary outcome and the progression of proteinuria in this analysis. But in the secondary analysis, in the exploratory analysis, there was a U-shaped relationship between sodium intake and rapid progression of kidney disease, which was defined as a decline of the GFR by 5% every year. And this is the result of the long-term MDRD study, which did not confirm this result. And according to this long-term follow-up, the MDRD people, which included 840 patients, there was no association between urine sodium and kidney failure or composite outcome, which was the kidney failure or all-cause death. Interestingly, there was a significant interaction between 24-hour urinary sodium excretion and urinary protein excretion. In the subgroup of patients who were on a low salt diet, less than 3 grams per day, and who had proteinuria less than 1 gram per day, high salt intake increased the risk of CKD progression, but high salt intake decreased the risk of progression in patients with proteinuria more than 1 gram per day. That we can comment on later if we have time. But this was an unexpected and interesting result.
Interesting. So, Dr. Afsar, does the restriction of salt intake decrease the risk of cardiovascular events, especially in our patient, Mr. Salty?
So, unfortunately, most of the data about this salt restriction and cardiovascular events comes from the population-based studies. For instance, this is a population-based study demonstrating that the composite cardiac outcome, major cardiovascular events, and cardiovascular death is related to salt intake. For instance, patients who had salt intake more than 7 grams per day had a higher cardiovascular death, cardiovascular events, and mortality. But interestingly, patients who had less than 3 grams of salt intake had also increased all-cause mortality, cardiovascular events, and cardiovascular death. And this was another study comparing the pooled pooled study, including transit and on-target participants. And overall, it included more than 100,000 people. And there was a U-shaped relationship between the sodium intake and the cardiovascular mortality in this study as well. And the presence of hypertension interacted with the results, significantly. For instance, in the patients with hypertension, there was a U-shaped relationship between sodium intake and cardiovascular death. And the patients who had higher and lower salt intake had increased risk of cardiovascular disease. This is another study in type 1 diabetic patients, and in this study also showed that there is a U or J-shaped relationship between salt intake and mortality in patients with type 1 diabetes. Lowest and highest. Lowest means the intake of sodium less than 102 millimoles per day, or highest sodium intake more than 187 millimoles per day, were associated with increased all-cause mortality and kidney failure. And this result was also confirmed by a meta-analysis done by Greudel et al. And compared with the usual sodium intake, both high sodium intake and low sodium intake were associated with increased mortality in this meta-analysis, confirming the results.
Since we have almost a minute left, but yeah. Can you just let us know real quickly, what's the best method to estimate the dietary salt intake for Mr. Salty?
Okay, so I think the dietary salt intake estimation is the hardest part of this task, because there are multiple methods, and like objective methods like urinary sodium excretion measurements, or subjective methods for like dietary assessment tools. But these are not ideally detecting the sodium intake of these patients, and there are some concerns specific to CKD patients, like disruption of the circadian sodium handling and diurnal variations, and they have large creatinine ranges, which might be a difficulty in interpreting the formulas and their outcomes. And the cognitive dysfunction also renders the dietary assessment tools not useful in this topic. So there is no gold standard to estimate the sodium intake in CKD patients, but under controlled intake conditions, that means that you provide the food to patient yourself, and you know how much sodium it has. And we need to measure the 3 consecutive 24-hour urine collection on 3 non-consecutive 24-hour urine samples to measure urinary sodium excretion, which is a hard task, especially it has a high financial cost, cumbersome, high failure rate of collection, and some patients are anuric, and we cannot have the urine sediment to examine at that time.
What's the best way to monitor the salt intake of Mr. Salty?
Given that we don't have any ideal method, we can do subjective methods like dietary assessment tools. They might be dietary recalls or dietary lists, but they are prone to underreporting the salt intake, and you cannot capture the variations, and some cognitive dysfunction, loss of motivation, and recall biases are impacting the results. There are some newly developing tools like urinary sodium chloride strips, but they need to be tested and validated in large and diverse cohorts, but they are simple and inexpensive when compared to urinary excretion of sodium.
So what are the strategies for salt restriction for him?
Unfortunately, there are two kinds of strategies. Which one is individual-based, the other is the population-based strategy. It's shown that individual-based strategies are not maintained after a certain period of time, or mostly after 3 months of implementation. The people with CKD and other people go back to their baseline sodium consumption level. So the best way to control sodium intake is to do a multifaceted approach, which includes the government and industry into the system. And there might be some ways to do that. For instance, government might implement some laws to restrict salt intake in the foods, in the processed foods. The government might set some upper limits of sodium included in the foods. And there might be some campaigns to educate the consumers and the patients. And one of the most important is that the front of pack labeling, which also renders the industry companies to decrease the sodium intake in the foods, and which also increases the consciousness of the patients to pick up the right food for their health. And there might be some policies to decrease the salt in processed foods. And these policies were implemented in some countries like Finland and UK. And after like 7 or 8 years, they were able to decrease their salt intake by 15% and decrease the prevalence of stroke and cardiovascular disease. Specifically to the renal kidney disease patients, dietary counseling is the mainstay of the approach, and it might differ according to the stage of the CKD, according to the proteinuria or the reason for CKD. We might educate people and patients to for health literacy, which means that they can pick up the right food for themselves, and we might encourage the patients to cook for themselves like fresh food and fresh vegetables at home. But just to remind that these patients are at the hospital like 3 times a week, and they may not have time to cook for themselves, and when they're out of their home, they just consume whatever they find, and there might be some problems like food insecurity, and they might not be able to pick up what they want to eat. There are some healthy diet patterns like Mediterranean diet and DASH diet, but these are, especially the DASH diet is rich in potassium, and currently it is not recommended in CKD patients. There are some self-management strategies, which includes education, web-based management, self-monitoring of blood glucose or urine strips. But as I said, these individual-based interventions are limited in terms of maintenance. Salt substitution is another option to substitute 100% of sodium chloride by 75% sodium chloride plus 25% potassium chloride versus potassium citrate. But this option does not seem promising for CKD patients as of now because they have the risk for hyperkalemia. And still, the current guidelines for CKD, KDIGO guidelines recommend the salt intake to be less than 2 grams of sodium or less than 5 grams of sodium chloride per day. And the use of salt substitutes are not recommended as of now, as a DASH diet is not recommended as of now.
So what happened to Mr. Salty? We did everything that you recommended. Got him to a dietitian for a personalized plan, increased his aerobic activity and lost 3 kilograms, learned how to read the nutrition labels, and increased his home cooked meals to add more vegetables and fruits to his diet. And within a 6-month time period, his blood pressure improved to less than 130 over 90.
So as the last slide, our take-home messages is that in patients with high blood pressure and high cardiovascular risk, there's a U or a J-shaped relationship between sodium intake and cardiovascular disease, cardiovascular mortality, and all-cause mortality. Yet we don't know the lower limit of sodium intake that we can recommend to CKD patients. But since these patients are at high risk for cardiovascular mortality, we are inclined to believe that they might have a U-shaped relationship between sodium intake and mortality and cardiovascular disease. The main problem in this issue is that we don't have randomized controlled trials in CKD patients specifically assessing the sodium intake and cardiovascular outcomes. And this is a main issue that we can address as nephrologists in the future. But until then, we can implement these findings found that patients at high cardiovascular risk to the CKD patients as for now. Thank you very much.
Yeah, you can skip it for a second. Yeah.
Thank you so much, Dr. Ejiofor and Dr. Elsurer, Afsar, for an enlightening and engaging presentation. We're now going to move to our Q&A so to see if there's any questions from the group from this excellent dynamic presentation. So please raise your hand if you have any questions. Yes, we'll start here.
Not question, but we must know that not every person is salt sensitive, which means that if you eat salt, some patients get hypertensive, some are not. The reasons for that, we call it salt sensitivity. But the question then comes, in CKD patients, are they more salt sensitive or not? Mostly salt sensitive. So do we have to decrease salt intake in all CKD patients?
Yes, salt sensitivity is a problem in CKD patients, and around 50% are salt sensitive. But they're at high cardiovascular risk. To my feeling, we need to restrict salt intake to less than at least 5 grams per day, but I'm not sure about the lower limit of that because I have no data to answer. And even in the studies with restrict or with controlled salt intake, like you give the food with a special with a predefined sodium in it, it's shown that the most of the patients do not achieve that low level of salt in their diet. So I'm not sure about the lower limit, but upper limit should be less than 5 grams, as I think.
Excuse me, I have a comment. So, do you mean by sensitivity in the glomerular side, or
No.
the sensitivity in the vascular, like endovascular?
No. There is a general term that's salt sensitivity, which means that if you eat salt, some healthy people eat salt, but they don't get hypertensive. The other people, when they eat salt, they get hypertensive. There is some mechanisms regarding for this. For example, impaired sodium handling in the tubules. They said impaired nitric oxide synthesis, increased sympathetic renal sympathetic system activity. This is the clinic definition.
What about the sodium excretion? Because it showed that the sodium excretion affected the outcome.
Yeah.
So were these people who have less sensitivity of the sodium?
In CKD patients, as far as I know, there is avid sodium reabsorption, as in
So they have less sodium in the urine.
Yeah.
Okay.
So I think as Shannon showed that there is already very high sodium intake. So we cannot we should restrict the sodium intake. Even we restrict, patient could not get at that amount. So they will always eat more sodium. So for the CKD patient, I suggest to decrease sodium because they will not decrease at that point. Yeah, if you say that if you eat sodium, it will increase sodium intake to 10 grams, salt intake to 10 grams. And the other issue, for example, there is basic change in the pathophysiology of sodium handling. For example, we know that we eat sodium. If the kidney is healthy, sodium is excreted by the kidney. It is true, but now we know that this extra sodium is deposited in the tissues, especially in the skin. This is associated with worse outcomes. So in the skin, this is an evolutionary protective, because when microbes came in the salty environment, they kill the microbes. But in diabetic patients, in CKD patients, it is chronically accumulated there, so it makes pro-inflammation. The pro-inflammatory mediators called circulation. So they are all this, but they are shown not standard tests. For example, they are shown MR studies, MR sodium studies. So things are changing about the sodium, for example. And the other reason for restricting sodium has independent effects other than blood pressure elevation. It directly includes vascular calcification, increased oxidative syndrome in the vessel wall. It makes endothelial dysfunction. So these are all reasonable things to cut sodium.
Reduce.
Yeah.
Well, thanks.
Yeah, just a comment. Yeah, it's regarding a little bit what you say on that. Well, about 25 years ago, when I was still in Venezuela, beautiful country. At that time, yes, I participated, in a preliminary study that we never finished in indigenous population living in the Venezuelan Amazonia. And that was already known that this patient had lower blood pressure than the other one. But it was an interesting situation because we examined 5 different etnias in this area. They were different people. And then we also examined the result, just blood pressure, of people that were living very close to the roads that connect with cities. This is a very huge area. So the thing is that these people, the blood pressure in these guys were around 90 to 100 systolic, and they were fine. But the same people living closer to the cities, the blood pressure was about 110, 120s, And then there was another, I mean, we don't have a control study for that, but there was another community that was kind of a ghetto in one of the cities, that then they had hypertension. We started seeing patients with CKD and other type of complications. So the point is that maybe, or this is an inference, but maybe salt intake was playing a role into that. Those people in this area, they don't eat salt. When they get to the city, they start eating more salt. Of course, they are exposed to other things, fat, whatever. No exercise, because these people are kind of nomads in the beginning. So there are different things that I don't know. I mean, it could be something related with all this we are rediscovering now. Having more data that can support these assumptions. Yeah.
Sorry, there are also epigenetic chains. It's where sodium epigenetically modifies the genes, so you eventually absorb more sodium in the renal tubules. These are,
Yeah, okay.
Yeah.
We're gonna,
Sorry.
this is great. We can continue the discussion after, but we'll probably have to move along. Thank you, Bars.
Wonderful.
Thank you.
Thank you both so much. Great presentation. I'm now proud to introduce and welcome Dr. Goldberg of Washington University as he joins me at the podium to introduce their fellows and the next presentation, Advances in Glomerular Nephritis. Dr. Goldberg, thank you.
Thank you very much. I'm honored to be part of the Fellows Renal Roundtable for another year. It's a great collaboration, it's a great discussion, and looking forward to our next two fellows who are going to be presenting each an individual case that will highlight some of the advances in medical decision-making and treatment for a couple of distinct entities. First, we'll have Dr. Yasir Baloch. He's going to go first, I believe, and he comes to us first from Pakistan, where he did his medical school training, and then his residency at Florida State University in Tallahassee. So he's now been with us this is his second year, and he is known for his for basically founding and running our Instagram account for our renal division. So if you see yourself on there with some compromising photographs, you can thank him for that. He also was helpful in basically spearheaded our recruitment video for this last fellowship cycle with some of his colleagues as well in the second year class. And the important part about that was he somehow managed to get security to let us onto the helicopter landing pad for our final closing shot from the drone. So it was actually a very impressive video. I'd say definitely worth checking it out on YouTube. And then after him, we'll have Dr. Olga Postovitenko, who will be speaking also about a clinical case and going over some management decisions. She comes to us from Ukraine initially, and then did her residency program at Berkshire Hospital in Massachusetts. So she is no stranger to cold weather. I think you can thank her for bringing the wintry mix we're getting here today here in St. Louis. So with that, I'll hand things over. Dr. Baloch, you have your kidney socks on today?
I do.
So do I.
Well, I'm audible. Thank you for your time. Also, thank you for people on Zoom who are joining. It's forward now. Okay, so I'll be talking about some complement-mediated diseases and discuss an interesting case and have some interaction with you guys. My patient, she was a 37-year-old lady. She presented at an outside hospital, G5P3 with like abdominal pain. She has a history of natural vaginal deliveries, no history of kidney disease, family history of any clotting disorder or autoimmune condition. She was found to have, the fetus was found to have persistent bradycardia. She was rushed to the OR and underwent a C-section, during which time a diagnosis of placental abruption was made. There was like documented 2 liters of blood loss, hypotension, and obviously she got some blood transfused. Right afterwards, the procedure, she was found to be anuric, kind of treated with supportive measures like IV fluids, and as you can see, a rapid uptrending creatinine. A CT scan kind of ruled out any structural damage to the collecting system. and at this stage, she was transferred to our hospital with concern for the severe AKI and help. This is an AI-generated version of our excellent campus, but as soon as she got to our hospital, nephrology, hematology, and urology were consulted. This was like a late Sunday consult. I came on board service on Monday morning, so I do remember it well. We gave some broad recommendations, autoimmune workup, antiphospholipid panel, renal ultrasound, some complement levels. We also ordered a genetic complement study right away, and the plan was like if she remains anuric, she might require dialysis within the next 12 to 24 hours. Not a lot here. You can see the urine analysis, which shows some blood, some proteinuria, renal ultrasound, some cortical necrosis, expected with severe AKI. And here are some labs for you guys. You can see the ones highlighted in red might be of kind of pertinent ones. Creatinine has gone up to 4.95 within like a span of 36 hours now. AST up to 869, LDH 4,090. The platelet count has dropped to almost 77,000, previously to 59,000, and haptoglobin was undetectable. Everything else kind of unremarkable. Of note, ADAM-TS is low normal but considered normal, and complement levels pretty much okay. Hematology was also consulted. They wanted to trend the haptoglobin and LDH. There was like some concern, low concern for DIC, but definitely concern for atypical HUS. The first peripheral smear did not show much, but they repeated another and it showed like 1 to 2 schistocytes. I know we all are thinking about a certain set of differentials, and we'll get there soon. Eventually, within the next few hours, later that day, she had some electrolyte abnormalities and required dialysis initiation. And we kind of were thinking, is this some form of TMA? We started paperwork for one of the complement inhibitors, eculizumab, got her vaccinated as well, started prophylaxis with ciprofloxacin. This kind of summarizes the picture in the first 48 hours. You can see the red line being the creatinine uptrending, the haptoglobin being the orange line, was undetectable for a short time, but without any intervention, started becoming detectable again. And the platelet count kind of stabilized, and if anything, you can see that blue line starting to rise up. And at this stage, we would I want to put you guys in our shoes, but we have a patient who has known heavy blood loss, hypotension, has this low platelet count which has stabilized, and the question is this AKI due to something as common as AKI-ATN, or do you think this is a complement-mediated process? And would you like to, if you want to scan the code, please, I would like you to participate. Would you just go ahead and give this patient eculizumab? Are you convinced? Because that's what we were going back and forth from discussion with myself and my attending. And while you're scanning that, okay, I think it should reflect this results live, but let me check. What? Okay, 3 participants up to now, 4. Whoa, okay. Majority want to give eculizumab. Peer pressure, I guess, you know. Plus, because it's probably if it's a non-eculizumab case, why would I be presenting it, right? Okay, I think we have a clear majority supporting eculizumab. Well, we kind of planned for it. However, we felt like we had a clear explanation of the AKI. I mean, a lot of times atypical HUS is a diagnosis of exclusion, and so around that time the urine output started increasing up, the platelet count started uptrending, the LDH haptoglobin became detectable. So we, after a discussion with hematology, felt like this patient had like some form of ATN and it would just recover all the time. So we decided not to give eculizumab. She continued on dialysis with expectation that there would be some renal recovery. This kind of shows the course inpatient. Anything yellow is the urine, and you can see progressively the urine output does pick up. The blue shows the ultrafiltration, which means she was getting dialysis every other day. And Unfortunately, she remained dialysis dependent despite some renal recovery. We had to find out patient care for her, and she was discharged from the hospital on day 17. By the way, the baby did just fine, in case someone was wondering. Before I tell you what happened further, I'll just give you guys a recap. All of you are probably familiar with the complement system, the classical lectin and alternate pathway. I think for us, the area of interest is the alternative pathway and how it converges on the C3 and then C5 eventually. I would like to mention factor H briefly because it will be pertinent to my talk later, but it is an important regulator of the alternative pathway, which is kind of spontaneously activated, and factor H kind of inhibits it to prevent any form of overactivation. It is very protective to our cells, including the endothelial cells at the glom and the rest of the vascular system. If you look at the structure of this protein, it contains like around 20 domains, each domain with 60 amino acids. The part with the blue is what interacts with the self cells and is protective, whereas the yellow is where it mediates the complement. And you can only imagine mutations at different amino acid levels can cause alteration of its function. Coming back to our case, so 3 weeks later, the patient is still dialysis dependent. This is outpatient, and the genetic testing that we had sent on day 1 comes back as positive. The way it was done was, and positive for a biallelic homozygous mutation of CFHR3, one of the complement proteins. In the initial testing I was told was negative, but once they do the MLPA, which is the multiplex ligation dependent amplification, basically looking for a lost segment in the DNA, it was a surprise to us because I must remind yourself, this was her 5th pregnancy. She's like late 30s, never had any form of kidney disease, hypertension, or any autoimmune condition. And I guess she's been carrying this mutation all this time. She already was showing evidence of renal recovery. She got 2 doses of eculizumab and was able, despite the delay, was able to get off dialysis. Unfortunately, was lost to follow-up eventually, but it was, a great learning opportunity for me in itself. Since we're talking about TMAs and atypical HUS, this is the kind of algorithm on, as per KDIGO's website. It might already be somewhat outdated, but it still helps me whenever I'm trying to work up these patients. You can see anything associated with GI infections would be HUS, anything else atypical. Big ones, which I frequently order if I'm thinking about it, is like the MMA and folate deficiency. Definitely infections, malignancies, a lot of secondary factors there. I really like this diagram here, and this is was published by Fahouri in Nature. But the conventional approach where we think if this is a primary versus secondary still is there, but it's getting outdated. And conventionally, pregnancy-associated TMA and TMA due to hypertension were grouped under the secondary category. This diagram kind of puts them in a separate entity of their own. They may or may not be primary or secondary, but I think recognizing them as potential correlators to primary or secondary is important. 50% of the primary patients, if not more, will require some form of a trigger, as you saw Our Lady, maybe a 4th pregnancy in her case. Definitely infection, a lot of chemotherapy agents. And the thing is, these mutations are very sporadic. There's incomplete penetrance, so it's hard to know if the family history would be of help or not. It's uncommon to have familial diseases with these patterns. When you guys would be, or you do deal with genetic testing, 5 common complement proteins of known significance would be the ones mentioned here: CFH, C3, complement factor B, CFI, and FCP. And again, all of them can have different form of penetrance and variation on how pathogenic they are. I must remind you that pregnancy-associated atypical HUS is not very common, but this is again from a French cohort study. When people do get affected, up to 70% of the people will end up becoming ESRD. That's why it's kind of important to take action early and be able to recognize it. That being said, common things being common, eclampsia, pre-eclampsia, HELP, and ATN are mostly what cause AKIs, and that's what we were thinking about our case. this is again, I feel like that's the treatment algorithm. We have more options now, and this could be outdated, and with KDIGO coming up with newer agents. But I think it's important to do check the anti-CFH antibody and eculizumab or alternate agents that we have that can help us. I got this a cut down version of a table. I think there were like 3 pages of it. From the recent KDIGO controversies conference from July, they went towards complement inhibitors. A lot of the agents were for C3G and IgA and other stuff, but after talking with Dr. Java as well, I think the area which will evolve and is evolving is all the C5 inhibitors and factor B inhibitors are of interest to us. You can see eculizumab and ravulizumab already there, ravulizumab being a longer acting agent requiring less frequent dosing. Crovalimab was recently approved for PNH, and there's a possibility you might see it for atypical HUs in future. Avacopan is being studied as well, and then there's some other monoclonal antibodies, again, like I said, factor B, and how it kind of binds to C3b makes a difference and is a great area for target for us. That being said, I think once you think about using a complement inhibitor, it's important to go institute it without delay. There's a protocol, you need to get vaccinated against certain organisms. And a more trickier decision is when to stop this treatment. I think that has to be individualized. A lot of time hematology does it in outpatient setting. There's a lot of factors that kind of weigh in terms of risk of relapse, infections, and costs. With this, I will wrap up, but yeah, you must remember 50% of the patients, even with primary complement-mediated disease, will require some form of a trigger. The way the genetic testing is evolving, I think our interpretation of these results will evolve. The gene that our patient tested positive for used to be a variant of unknown significance, and now with more studies, it is a more pathogenic variant, so it just keeps on changing. And I think that's my short experience in nephrology. I think diagnosing TMA is very easy, but knowing what exactly caused the TMA can become a blurred picture. And these are some of my references, and I'll hand it over to Olga.
Okay, so again, thank you so much, everybody, joining us today, especially in such a cold winter night. And I feel like I have mission impossible today to cover IgA nephropathy in 10 minutes. But I will try my best to at least give some highlights of the newer therapies that currently we have. Okay, I don't have any disclosures, and let's start from the case right away without any delays. So here we have a 21-year-old male who previously had absolutely normal renal function and hypertension, presented to the hospital with hypertensive emergency and AKI. So his history actually started back in 2018 when he was following with pediatric nephrologist. At the time, he was diagnosed with IgA nephropathy purely based on the clinical picture because he has sporadic episodes of hematuria after some upper respiratory illness. He was doing fine, but later on in 2023, he was diagnosed with hypertension and was started on irbesartan. In January 2024, because now he reached adulthood, he transferred his care to adult general nephrology and had his first initial appointment with us. At the time, his creatinine was 1.1, but we noted to have on urinalysis dipstick +1 proteinuria. Some additional workup was ordered and patient has scheduled close follow-up, but unfortunately he lost. The next time we see this patient is already in November 2024, when he came to the hospital with hypertensive emergency. Blood pressure was above 200 and new AKI with creatinine 2.18. So as I mentioned before, there is a brief summary of his past medical history, the IgA nephropathy based on the clinical picture, hypertension, obesity, anxiety disorder, and some hyperlipidemia. Otherwise, nothing much remarkable or pertinent to our story. On review of system, patient reported some nausea, vomiting, decreased oral intake, frothy or cloudy urine, some headaches, and lower extremity edema. Physical exam overall unremarkable except of +1 lower extremities edema and blood pressure 215/105. This is initial blood work, so overall something that catches your attention is BUN of 42 and creatinine 218. The rest looks relatively normal. Here we go with urinalysis, which showed 3+ hematuria, proteinuria, 24 urine protein collection was 2.9 grams overall, and renal ultrasound was unremarkable, unrevealing, and negative for renal artery stenosis. So long story short, patient obviously got the renal biopsy done, and it showed confirmed the diagnosis of IgA nephropathy, also found to have acute tubular injury and some mild interstitial fibrosis and atrophy, as well as mild arteriosclerosis. There is a type of focal global glomerulosclerosis was 3 out of 15, and mass C score was M2, E1, S0, T1, and C0. So given this picture, obviously we have to treat this patient somehow. So let's quickly overview how. What options do we have? So before making any decision what medications to start, we have to always consider overall clinical picture and try to risk stratify those patients. What patients will have the higher risk of rapidly progressive IgA nephropathy with rapid decline of the renal function. So regardless of the initial presentation, we have to attempt to start all the patients regardless of the initial presentation on the supportive measures, like lifestyle modifications, blood pressure control, weight loss, and if patients don't have any contraindications, ideally all of them should be started on some sort of RAS inhibition, SGLT2, newer medications such as endothelin inhibitors and MRAs. And then the second part is a little bit more trickier. So here we have to think twice which patients are actually qualified for immunosuppression or disease-modifying therapy. We have few agents right now available in the market. Some of them are older, some of them are newer. And we have to think several times before actually deciding which patient qualifies for which therapy and when. So it seems like since 2020 or 2021, we have the new era of IgA nephropathy, but basically each year from that period, we have new medication registered or approved or receiving accelerated approval for treatment of IgA nephropathy. So everything started from SGLT2 inhibitors, then we received sparsentan, budesonide, sparsentan, and the recent most newer medication that was improved is complement inhibition that literally received accelerated approval in August 2024. So by now, I assume at least that majority of us had at least some experience using sparsentan and budesonide in our clinical practice, so I'm not gonna talk much about those medications, even though they're great. I'm gonna highlight just two newer ones that might have a little bit more interest to them at this stage. So one of them, we know that variety inflammatory or fibrotic pathways can be activated by mesangial galactosidase IgA deposition. And complement system appears to be among of the most consistent with the severe progression or presentation of the disease and overall worse outcomes in those patients. So right now, or in IgA nephropathy, the major two pathways in complement inhibition play the role. One of them is alternative that we heard a little bit earlier during the Baloch presentation, and the lectin-1. So right now, we have the new medication that inhibits complement C3, specifically factor B, and the name of the medication is iptacopan. Here we have the most recent publication about one of the phase 3 clinical studies that done with this medication, which shows significant reduction of proteinuria. So basically 35.8% and 38% based on the 24 protein urine collection and spot UPCR. And based on this basically findings or data, medication received accelerated approval and ready to use for our patients with IgA nephropathy and high risk of progression. So what about the other pathway? So we all know that in IgA nephropathy, important role plays the mucosal kidney access, when B cell can, on the level of mucosa, can activate, B cells can be activated by the environmental or genetic predisposition, and eventually it will lead to the cascade of the reaction which will participate or form a pathogenic galactosidase IgA in serum, and eventually in mesangial deposition and IgA nephropathy as a result. So right now, again, I think we have at least half a dozen of different clinical trials on different stage of investigation, kind of investigating the benefits of B-cell therapies. I won't have time to stop on all of those trials or all of those medications, and just highlight one of them. It's atacicept, which seems to be a dual BAFF and APRIL antagonist. So this is very interesting study, phase 2. It had 2 stages. The first one, 36 weeks, it was placebo-controlled double-blind study when patients been assigned to 2 different groups, one of them obviously receiving atacicept in various doses, and then the other one is placebo. And the patients who've been enrolled in this study is basically the patients who already been on maximal supportive treatment with RAS inhibition, but despite that still have significant proteinuria. So after patients successfully finish the first initial 36 weeks, then they've been enrolled in the open label study, and they start receiving fixed dose of atacicept of 150 milligrams weekly. This is injectable subcutaneous medication. This study had several endpoints. One of them was obviously reduction of proteinuria, then decline in Ejiofor, also a reduction of hematuria and reduction of galactosidase IgA in the serum. And as you can see, based on the results, medication showing very promising results so far. So in terms of the reduction of hematuria, 75% of the patients been able to achieve it. 66% of reduction in serum galactosidase IgA, and then 52% reduction of proteinuria from the baseline. And I think the most exciting part is the effect on the renal function and progression of renal disease. So over the 90 days of observation and taking this medication, patient had only 0.6% of Ejiofor reduction, which is amazing, because based on the information that we have right now and medications that we are commonly using, none of them unfortunately didn't demonstrate such a remarkable result. So the maximum effect or slowing down of progression of the kidney disease or Ejiofor was 1.2% with MMF use, and it was limited only to Chinese population. The rest of the medication, unfortunately, at this time failed to show such a remarkable result on affecting the Ejiofor slope over the year. So we coming to the end, and there is no presentation without a little bit of entertainment, so get your phones ready again. There is no right or wrong answer. Just based on the information and previous information that you know already, how would you approach this case of this 21-year-old patient with worsening proteinuria and renal function? Would you just start or continue the supportive treatment, or maybe you consider some disease-modifying agent or immunosuppression? How would you? And I think I need the help of the friend.
Tech support.
Tech support. Oh, here you go, interesting.
It's gonna be all over the place.
Yeah. Okay, we'll give a few more seconds. So we have some adventurous people trying to, or willing to try all the new medications. Okay, so it seems like still going. Okay, so very interesting distribution. So I'm happy to see that some people are ready to some innovation and trying newer medications. And I think that that's why the IgA nephropathy is so much exciting and fun today to work with and to deal with those patients. Again, there is no right or wrong answer, just like interesting to see how open the audience to something new. Even it's just accelerated approval of the medication, and it seems like 2 people at least are ready. Okay. And the end. Okay, any questions?
For the iptacopan study, there is no difference with GFR, right? They decrease compared to other. They decreased proteinuria, but GFR, as far as I know, GFR does not different between the groups, right?
So unfortunately, at this time, we even don't have the published data about it. So they're still investigating, and we don't have the information. They didn't publish it, and the approval came just on the proteinuria deduction, nothing else.
Yeah.
What did that patient eventually get?
So the patient actually, he was a little bit older case. I kind of inherited him. So he received systemic steroids, reduced dose by protocol like test and trial. So after, I don't remember the duration of the systemic steroids, but his creatinine significantly improved. Most recent one was 1.3, and his proteinuria right now 0.4 grams.
Wow.
Yeah.
What's more expensive?
And obviously he is on RAS inhibition, and basically that's it, just a supportive treatment. And as you do, yeah, he's doing good.
Since we have time, I'll take a selfie with the crowd. You need to visit as well. Thank you.
Great job.
Very good.
Awesome. Thank you so much for that excellent presentation. I am so thrilled that we had such dynamic discussion and wonderful topics for this evening's Fellows Renal Roundtable, and just want to give a big thank you to our sponsors and our presenters for their time spent speaking on these timely topics, and we hope that you'll continue to stay connected with the National Kidney Foundation. If it's your first experience with the NKF, please reach out to Kathleen at kathleen.davis@kidney.org to learn more about the work of NKF. And please be sure to sign in at the table out front if you haven't yet done so. We really appreciate you checking in for our attendance records. And all the participants from tonight's program will be receiving a thank you follow-up email that will include a feedback survey, and that feedback's really helpful as we plan upcoming programs to make sure that they are informing and engaging to all of our renal community members. Again, I want to thank our presenting sponsor, Therapeutics, gold sponsor, Alexion, and AstraZeneca, and to our silver sponsors, KZ, Otsuka, Amgen, Calidus, Akebia, Adrilix, Aurinia, Baxter, CareDx, Fresenius Medical Care, CorMedix, Boehringer Ingelheim, Merrick, Natera, Novartis, Novartis, NX Stage, Fresenius Medical Care, Renal Pharmaceuticals, Bayer, and Mallinckrodt. That was a lot. Thank you, everyone, for allowing us to gather and supporting this evening's program. It's been such a joy being here tonight with you all, and I'm now going to pull a lucky winner from the raffle basket. Woohoo! Cross your fingers and your toes. Okay. Oh, he's gone, but Dr. Kunal Malhotra won. So we will track him down and make sure he gets it. Thank you all again for joining us, and have a happy holidays. Thank you.